Erica. Thank you so much for joining us. Could you just tell us a bit about what your role is in Glasgow or with the NHS?
Okay, well, I'm a consultant physician. My official title is a consultant in infectious diseases and general medicine, so I work in the hospital setting, but also doing outpatient work as well. And in terms of the subject today, so is about HIV. So I'm the clinical lead for clinical services for the HIV outbreak that's currently going on in Glasgow City Centre.
So we are within an outbreak of HIV, maybe about almost 3 years or just over 3 years into this outbreak. So at the beginning, when you first started realising that this outbreak was happening within injecting drug users in Glasgow City Centre, what were some of the challenges there that you were seeing as a service providing treatment and care to HIV population?
Yeah, well, I guess because of our background doing a lot of hepatitis C work, and I previously and continue to do services in the prison sector and in addiction services and in some of the GP practices, although not in the city centre, we had an idea about some of the difficulties that we would have, but clearly this is at the extreme end of the vulnerable group and the extreme end of patients that are unlikely to engage in standard care. And our existing services, by and large, apart from these prison services, were centralised in the hospital for good reason originally, because that meant that all the additional services that people needed were in one place, and that was in Gartnavel General Hospital. But that's some distance from the city centre, and although it's got reasonable public transport links, patients would be expected to turn up at a set appointment time on certain clinic days, and that is very challenging for these patients because they've got so many other difficulties and other demands on their time that they're not going to engage in the standard care. So we had to think about how to address that and how we were going to try and reach out to them so that we could get them started on treatment, because there was two aspects to it. One was the treatment for the individual person, because we know that treatment can improve the individual outcome, but there's also the public health aspect of it to try and get patients on treatment to stop them transmitting the HIV forward.
Yeah, which is really important.
Yeah.
And lots of education and lots of trial and error with some of the changes that you were making to services.
Well, I guess it was there was existing services supporting this group, so it was really a question of finding out what those services were with the homeless community largely, and just to see how we could link in with the existing services that were there. So that just takes a little bit of time, unfortunately. It's not something that just happens overnight. And then just to work out how best to set up services for people. And there are limitations on staff and staffing, and that's a key aspect of this. And the hospital-based staff, we're still having to do their other jobs and their existing workload as well. So it's very time-consuming work and very labour-intensive work to try and track down individuals, see where they are, engage with them, and then develop a relationship with them, so that they are, encouraged to come and get treated. So, yeah, definitely time and sort of building bridges with different services as well as the patients, I think.
So, what does let's say the city centre treatment clinics look like now?
Yeah, so we've now got quite a well-established clinic that works out of the homeless addiction services, so an existing, NHS facility, but its location is right in the city centre, so the vast majority of patients certainly at the beginning could walk to that clinic, and a lot of them were attending anyway for their primary care and addiction support anyway. So it had some room availability, although the space is limited. That is a challenge. But we were able to deliver a service. Initially we set it up as a nurse-led HIV service because we didn't have any support for consultant support for that. But now we have a consultant service there as well, and it's once a week. Initially, when we had it as the HIV service, we really had very poor engagement in care, and there was probably a number of aspects to that, but one of them may have been the sort of stigma associated with HIV. Because our team do all bloodborne viruses anyway, and hepatitis C obviously is a big issue for this population, we just changed it into a general bloodborne virus clinic. And I don't know if it was just a question of time or whether that taking away that stigma of anyone coming to this clinic has HIV, which is not the case now. maybe helped engagement in care.
So in terms of the population that you are seeing out in the city centre at the clinic, what are some of the additional barriers that population are facing that maybe you or the nurses or your team is supporting with?
So a lot of them, I mean, I think the major barriers are things that in some respects we can't really support them with directly, but because of all the links and things we've made now, we know how to try and help them as a sort of more of a sort of team-based approach, because mainly the issues are around, you know, addiction, mental health issues and homelessness. And a lot of them are, you know, as well supported as they can be in that situation anyway, in that centre that they're going to, and some of them are supported by third sector organisations, by mental health services, and obviously by the addiction teams that are there. So it's really just about trying to link it all together. What we do is, in the patients that are really struggling, patients that are maybe not on treatment, perhaps have limited engagement with addictions, but really have addictions at the heart of their problems, we do have a sort of regular case review of, we call it a complex case review, although I think almost every patient is complex in some respect. But and we meet with the senior addiction staff regularly to discuss these patients, to see what additional things we can do to try and support them. You know, obviously from my perspective, to engage in care, but a more sort of holistic approach to all the issues that they have, because they're not going to engage in their HIV care if we haven't sorted out the other problems.
So there's some people that are still maybe that added complexity and maybe not engaging in the treatment as we would like to see, but we are having successes, or you guys are having successes in people engaging in treatment and adhering to their treatment. Could you tell us a little bit about that?
Yeah, so I think actually the vast majority of our patients have done really, really well, and you know, we've managed to get, well, it depends when you look at the statistics, but between 80 and 90% of our patients are on treatment with good suppression of their HIV, and that's what we're aiming for. I think it's much more likely in this population to have hiccups in that pathway. It's not a sort of start treatment and there's no problems at all, because of the social issues that they have and the other things that we've mentioned. Things come up, the addictions issues become a little bit less controlled, and we have difficulties around that, so they stop taking their treatment. So they certainly need a much more intensive approach and a much more, much closer link to care. But it's not to say that these patients can't take their treatment, because they clearly can, and you know, some of them do extremely well, just as well as any of the other patients that come up to our services. So I think that is maybe something that we knew that because I've worked with this group before in other respects, but just not in the same volume as we have recently. But just because you have addiction issues, or you know, you've got mental health issues, it doesn't mean to say that you won't be compliant with your therapy. And I think that's something that people that don't work in this group just make an assumption of. And so we just need to support those that do struggle with it, though, you know, much more than we might otherwise have to.
So what are you maybe thinking for the year ahead? So obviously we're at the end of 2018, so what do you think 2019 might look like for service and care?
We're obviously hopeful that we're coming towards the end of the formal outbreak, because we have had so many, you know, so much input in terms of the public health approach to it and our aims, treatment as prevention. So we have a cohort, an active cohort of over 100 patients. These patients are going to have ongoing needs. Their addictions issues aren't just going to disappear overnight. We know that if you treat HIV, you know, you can have just as good a prognosis if you're, you know, picked up early and you take your treatment. So these patients need to be looked after ongoing, lifelong. So, you know, this is a group of patients that are on average in their 40s. You know, we'd expect them to have 30 more years of this. So the big challenge is to make sure that the you know, in this sort of time of austerity, that the service provision is supported. It's slightly challenging sometimes to argue for it, because it's really so time intensive and labour intensive. We need lots of staff to run this, and sometimes the results that we see, because they are actually quite good, might suggest that maybe we don't need quite as much input as we have, but we certainly do need that. So we need to continue to make sure that the NHS supports this, particularly in terms of staffing, nursing staff and consultant time. You know, addictions needs to be absolutely supported. I think the other sort of things that we're continuing to do is that, a lot of these patients are co-infected with hepatitis C, so we've had a really big focus on hepatitis C over the last year, and we'll continue to do that because hep C treatment is really easy, and it's really important in HIV to treat your hepatitis C because of increased risk of liver disease in this population. And the other aspects that are really sort of minor things, but we didn't have proper vaccinations sorted out in the clinic area, and we're about to get that all organised. But yeah, so I think more of the same, but make sure that we have the whole service properly supported, ongoing support for the service.
Because actually, if when the outbreak is maybe declared to be maybe over, but it's not over for the people that have been affected by this, it's maybe a really important point.
Yeah, we won't. That's right. We may not see the new numbers, but we still got over 100 patients, and they're high users of unscheduled care. They're in and out of A&E departments and all that sort of stuff. So, they say that on average the cost of an HIV diagnosed NHS is 360,000 a lifetime cost. So that's for a patient that's maybe quite straightforward, and these patients won't be straightforward. And if they become ill because of their HIV, because we're not supporting them properly, that will be desperately expensive for the NHS and obviously a cost to the individual person. So.
Thank you. Erica, is there anything else that you'd like to add, or any final points?
No, I guess the main thing to say is that you absolutely need to work with the existing services on the ground and just understand how they work, because it is it is an unusual situation. Although I know that with integrated boards and all the rest of it, it is a changing situation. But it's unusual for hospitals to deliver services in the community still. And although we've done it for other reasons, and it is changing, you do need to try and understand how other teams work as well, and they need to understand you. So it does take a bit of time just to kind of settle in and bed in, and probably just need to make sure you sort of develop those relationships and have an understanding of what the other teams do, as well as what you want to achieve yourself. So.
Thank you.